turn it over to my colleague, Dr. Maria Buti, who's the professor of medicine and consultant of hepatology at the University Hospital Vall d'Hebron in Spain, and was the leader of the Public Health Committee for the European Association for the Study of Liver as well. And we'll give her perspectives on these guidelines, and again, how they relate to practice settings in Spain and more broadly other high-income settings. Maria, welcome, and please speak slowly to benefit the interpreter who's seeking to help that section of our audience follow along. Thank you.
Thank you. Thank you, John, and all of your team. Good day to everybody. My task today is to speak on the impact of new WHO hepatitis B guidelines in high-income countries. I don't know if it's possible to see my slides. Can you see my slides?
They're coming up, I believe. Yes. Can you?
Okay. According to the World Bank, there are 86 countries classified as high-income economies, and the majority of them are in the Northern Hemisphere. The prevalence of hepatitis B in these countries is lower than in the low-income countries, and also these regions have specific guidelines for treatment of hepatitis B. American guidelines, European guidelines, Asian Pacific guidelines. It's important to realize that high-income countries are very heterogeneous in terms of models of care. Some of them have universal healthcare services, and others are based in insurance systems. Reimbursement mechanisms are different, and also clinical pathways and access to drugs are not uniform. And I would like to highlight that in high-income countries, there is an increased number of migrants. Globally, an estimated of 281 million people living outside their country. And if you look at my region, at Europe, it's approximately 36% of the global international migrant population. And this population is usually more affected with hepatitis B than the local population. So migrants usually have more difficulties to access and to integrate into the healthcare systems of the host countries. They have language and cultural barriers, stigma, and all of these translate in a higher risk of negative health outcomes. And I think for these underserved and marginalized communities, the WHO guidelines are particularly useful in high-income countries. Wendy has shown the gaps in testing and treatment. This happened in all regions. Even in European region, the rate of testing, it's relatively low, 9%, and those on treatment, only 8%. So clearly, high-income countries needs also to scale up testing and treatment if we like to reach the WHO goals. And this means a radical simplification of care and expansion of treatment criteria. And I think this is the goal of these new guidelines. Let's look at the challenges in the European region. And this is a nice review with Erika Dufel from European CDC that will look at what we need to achieve hepatitis B elimination and the challenges. And still some European regions have a high burden of hepatitis B virus infection. Viral hepatitis deaths greatly exceed those attributed to HIV or tuberculosis, and there is, as I mentioned before, a considerable variation across different countries and across different populations, particularly in migrant populations. Diagnosis, it's still low. We have a high proportion of cases remains undiagnosed. Hepatitis B vaccine as well as drugs are available, but still suboptimal coverage in many countries, and also suboptimal coverage in hepatitis B vaccination. And this is related particularly because in some countries it's not included in the national health care system testing for hepatitis B, and also because we cannot access to screening and treatment at the community level. That for me, it's critical in high income countries to provide all of these services at the community level, particularly for vulnerable populations. So I think we have discussed previously the 5 key points of the new guidelines, and the most important probably is related to treatment, to increase treatment, and some of these criteria can apply very well in high-income countries to treat at the community level. And these are significant fibrosis or cirrhosis evaluated by non-invasive markers, APRI and transient elastography. At the community level, transient elastography is not available for everybody, so APRI it's very, very useful. A different point of care way of testing HBV DNA, and a new recommendation that it's aligned with the growing epidemia of fatty liver disease, that is the presence of any of the following co-infection, family history of liver cancer, immunosuppression, comorbidities, and extrahepatic manifestations. It's a different way to view hepatitis B in a more integrated way than only hepatitis B alone. So point of care testing, very useful in high-income countries to detect viral hepatitis at the community for screening, and also testing for viremia to select patients in a different ways with the gene expert, but also with dry blood samples. So this type of assays are an alternative to initiate treatment and also to monitor treatment response. Reflex testing, also a way to simplify and to start quickly treatment. It clearly allows for a reduction in the number of visits and promoting linkage to care and treatment. And this is particularly useful for populations that usually don't are attending the classical healthcare systems. Non-invasive methods, I mentioned before that not high-income countries have access to FibroScan. There are some small hospitals and also at the community that even having portable FibroScans, we cannot access. So having these non-invasive markers to establish the presence of significant fibrosis and cirrhosis, and these lower cutoffs are very useful to start treatment, and this can be performed outside the hospital setting, big advance to increase the number of patients that can be treated. This is an example of a study that we are now doing in Barcelona at the community level, applying all of this, and with a rapid testing, with confirmatory testing, we can treat patients, treat and vaccinate those without infection at the community level. And this is particularly important for migrants. Regarding treatment, usually the majority of high-income countries have access to treatment to all of these drugs. Usually is not an issue, but the issue is, and these are recent data showing that some of these drugs needs to be prescribed at the hospital level, not at the community level. I think these new guidelines promotes treatment at the community, and this is useful not only for the patients, also for our policy makers to change the approach of treatment for hepatitis B. I would like to finish with mother-to-child transmission, that it seems that it doesn't occur in Europe, but if you look here, mother-to-child transmission is the main transmission category for hepatitis B, despite regardless having access to hepatitis B vaccine. In some European countries, the coverage with the 3 doses of hepatitis B vaccine is suboptimal. For the reason, this new conditional recommendation to use antiviral prophylaxis for all HBs antigen-positive pregnant mothers without the need to perform viremia and e-antigen status will be useful to try to reduce in this suboptimal coverage of hepatitis B vaccination to reduce transmission of hepatitis B. And finally, Delta, the most rapid and progressive viral hepatitis, usually is underdiagnosed. And I would like to share with you data from my center on testing for Delta. Testing for Delta, it's very low. It's approximately 10–11% among those HBs antigen positive are testing for Delta globally at the hospital and at the community. And we started 3 years ago with reflex testing for Delta. Reflex testing for Delta increased the number of people tested for Delta. And also for me, what is really important, we increased the number of patients diagnosed with chronic hepatitis Delta, and more than half of patients with Delta didn't have any risk factors, showing that testing based on risk factors is not the best way to go. And reflex testing allows to increase, to identify a higher number of patients with hepatitis Delta. In summary, the WHO 2024 hepatitis B guidelines are an opportunity to transform care, even in high-income countries. And as Wendy mentioned, these guidelines are addressed primarily to physicians, not to liver disease specialists, to physicians, primary care physicians, policymakers, and I think we need always the involvement of policymakers to change the approach to hepatitis B. Clearly, the priority areas identified in these guidelines are key areas, and I think even high-income countries need to support these guidelines. Thank you very much for the invitation.
Thank you, Maria. Excellent overview, touching on a number of key points and how they can apply to special populations such as migrants, which in many countries, including the United States, they have the highest prevalence of hepatitis B. And it's really an important community to reach. So thank you very much.